Welcome to The Explainer. Today, we're diving into a fascinating biological mystery that plays out right inside the human heart. We're going to decode aortic valve stenosis. We'll be looking closely at what actually happens when the vital machinery keeping us alive fundamentally alters its own structure. 13.6 million. That is the staggering global burden of calcific aortic stenosis. We're talking about a condition that's responsible for nearly 150,000 deaths every single year. So the sheer scale and urgency here are massive. And as global populations age, well, that number is only going to multiply. This isn't some rare anomaly. It's a major worldwide health challenge we literally can't ignore. To really get a handle on what this disease does, we have to start with a foundational question. What happens when the heart's main door just refuses to open? Think of the left ventricle of your heart as this incredibly powerful, tireless pump. The aortic valve, that's the main door out of that pump. It swings open to let oxygen-rich blood rush out to the rest of the body and then snap shut so it doesn't leak back in. But what happens to the pump when that door gets jammed?
Section 1. The heart's main door.
Let's take a closer look at the physical architecture of that door and how it structurally fails. There's actually an incredible variety in how this breakdown happens. You've got the normal, healthy tri-leaflet valve, 3 delicate, highly flexible flaps. Now, about 1 to 2% of the population is born with a bicuspid valve, meaning it only has 2 flaps. And while those bicuspid valves are definitely prone to stenosis, the scientific reality today is that calcific aortic valve disease is the most common cause of stenosis in adults. And here's the wild part. This can happen even in people born with a perfectly normal 3-flap valve.
Section 2. More than wear and tear.
So how exactly does a totally healthy valve become heavily calcified? Well, we need to clear up a massive misconception right now. For the longest time, the old myth was that the valve simply wore out as we aged, just, passive wear and tear. But the scientific reality, aortic stenosis is an active, incredibly complex biological process. It's driven by inflammation and lipid infiltration. Your valve isn't just wearing down, it's actively transforming. It's a fascinating and absolutely crucial distinction that completely changes how we approach treating it.
Let's walk through these steps like a detective examining a crime scene. Step 1, the delicate inner lining of the valve gets damaged, which allows lipids, fats, to sneak right in. Step 2, this lipid invasion triggers an intense inflammatory response. And then step 3, the fibrocalcific response. That flexible, pliable valve tissue slowly becomes stiff and immobile. The cells inside the valve literally undergo what's called osteogenic reprogramming. They essentially start acting like bone cells. Crazy, right? Down at the microscopic level, the cellular machinery at work is just mind-blowing. You have lipids entering, inflammatory cells reacting, and eventually the formation of calcium hydroxyapatite. That is the exact same mineral found in your teeth and bones. So the valve interstitial cells basically undergo a transformation mimicking skeletal bone formation. Your heart valve is quite literally turning to bone. So the crucial takeaway here is this. We know the door is turning to bone and getting stuck. But what does that actually mean for the pump? How does the rest of the heart react to a stuck door?
Section 3. The left ventricle's response. Now we're shifting our focus from the microscopic valve to the macroscopic impact on the heart's main engine. When that valve is obstructed, the heart has to push incredibly hard to get blood through a tiny, narrowed opening. This leads to hypertrophic remodeling. The left ventricle actually thickens its walls. It's kind of like a bodybuilder bulking up to lift a heavier weight. Initially, this is a clever adaptation to reduce wall stress and maintain pumping power. But over time, this massive thickening becomes highly maladaptive and downright dangerous for the patient. Let's look at how this builds into an even bigger problem. When that heart muscle is forced to work too hard for too long, you start seeing myocardial fibrosis. That's scarring right within the heart muscle itself. The imaging and biopsies capture this scarring perfectly. And here is the scary part. While some diffuse scarring might improve if you go in and replace the valve, what we call replacement fibrosis doesn't just go away. That damage, it's permanent. And all that thick, scarred muscle creates a brutal physics problem: myocardial ischemia. An enlarged, overworked pump demands a massive amount of oxygen for fuel. But because of the restricted blood flow and the increased pressure, the system simply cannot deliver enough oxygen to the heart muscle. It's a severe supply and demand mismatch, and it sets off a huge cascade of clinical problems.
Section 4.
recognizing the warning signs. So, how do all these internal, microscopic, structural struggles actually show up in a living, breathing human being? Patients classically present with a specific triad of symptoms. Exertional dyspnea, or shortness of breath, happens because the stiff left ventricle causes fluid to back up into the lungs. Angina, or chest pain, is a direct result of that brutal oxygen supply and demand mismatch we just talked about. And syncope, or fainting, occurs because the stuck valve literally prevents the heart from pumping enough blood up to the brain during exertion. Oh, and there's also a fascinating link to gastrointestinal bleeding, known as Hyde syndrome, which is caused by the sheer physical stress the blocked valve puts on blood elements as they squeeze through. Now, you might be thinking, a doctor could just listen to your chest and immediately know how bad this stenosis is, right? But check out this quote directly from the source material. Auscultation has a very low sensitivity of diagnosis of AS, even when performed by an experienced health professional. A stethoscope simply isn't good enough anymore to reliably rule out severe aortic stenosis. We need something a lot better. And that something better is echocardiography. It is the absolutely indispensable gold standard imaging technique. Using sound waves, an echo allows doctors to directly visualize the stuck door and measure exactly how fast the blood is being forced through it. Sometimes supplemented by a CT scan or an MRI, this is the only true way to see the struggling pump and confirm exactly what is going on, the etiology, and the severity. When we look at who actually gets this disease, distinct clinical patterns emerge. There are strong correlations with age, diabetes, and hypertension, and this perfectly ties back to what we were discussing earlier. Aortic stenosis is not just passive aging. It shares many of the exact same active inflammatory risk factors as vascular blockages and general heart disease.
Section 5. Staging and disease course. Once it's diagnosed, how do we track it? Doctors need a structured way to decide when a patient actually needs intervention, and they use an A, B, C, D staging system. Stage A means you're at risk. Stage B means the valve is progressively narrowing. Stage C means the stenosis is severe, but, remarkably, the patient still feels completely fine. No symptoms at all. It isn't until stage D that the classic symptoms of shortness of breath, chest pain, or fainting appear. It's an incredibly stealthy progression, literally hiding in plain sight until the cardiovascular system is already under immense strain.
But here is where the science gets really exciting. The future of this staging system is actively evolving. Because we know that the heart muscle suffers permanent scarring before symptoms even show up, future staging systems may incorporate evidence of the left ventricle's struggle, like fibrosis seen on an MRI, much earlier in the process. The ultimate goal is to catch the heart's struggle before the damage to the left ventricle becomes permanent. Which leaves us with this final, truly provocative question to ponder. If we know that the heart's machinery actively rebuilds itself into bone through very specific biological pathways, how close are we to medically reversing this process before the main door shuts completely? Can we one day halt this osteogenic reprogramming with a simple pill, rather than waiting for the door to jam shut so we can surgically replace it? The sheer biology of this condition is absolutely fascinating, and the future of cardiovascular medicine has really never looked more promising. Thank you for joining me on this explainer. I hope you walk away with a crystal clear understanding of the incredible mechanics of aortic valve stenosis.